Well, thank you everyone for spending part of your evening with us to learn about EBK. And I am going to move on here and do a little history. Does less traumatic epithelial removal lead to less pain and faster return of vision? Well, there were anecdotal observations from laser surgeons and their staff in the US and Israel in particular. So Yariv Baron is an optometrist who noted, while he was assisting surgeons, that if they did PRK with a rough epithelial removal, and they just were very quick, lots of pressure, lots of swatting, that the patients who Yariv saw the next day had a lot of pain. But if the surgeon was very careful and tried to remove them smoothly with little pressure, gentle, and tried to take them off in sheets, that the patients were much more comfortable. So he spent a great deal of time developing this unique instrument to minimize trauma to the epithelium, Bowman's layer, basement membrane, and the stroma, and leave the bed completely clear. So
Beautiful.
this is a close-up of the device, deceptively simple, no moving parts, disposable, and it scoops up the epithelium in layers very gently. And the epithelium gets scooped up into the device itself, as you see here. And you will see in a moment a video of Dr. Kanelopoulos in Athens using the device. At any rate, it's the only procedure that leaves Bowman's layer completely intact with a clear bed, no debris, no scratches. This here shows the various levels at which refractive surgery currently takes place. Way down at the bottom, old-fashioned LASIK with a microkeratome. Above that is a much shallower, thinner flap that you can create with a femtosecond laser. Then you see where the spatula hits and where EBK cleaves the material. EBK actually spares Bowman's layer and even spares basement membrane. This directly impacts treatment accuracy, pain, complications, and the healing process. So this is just another picture showing the scooping, the gentle scooping in layers. This is the healing mechanism. You see in A that there's actually a beveled edge, that the epithelium, which is 5 layers thick, there is a bevel at the edge, which you see in B, allows the epithelium to march in very quickly and slide and divide, which is why in C, the healing mechanism is so incredibly rapid. So I use EBK as my preferred form of surface ablation and anytime I need to remove epithelium, because it provides less post-op pain, less haze, and superior clinical outcomes. So once again, basement membrane and Bowman's layer are spared, and this has been shown histologically. And there is minimal rupture of epithelial cell membranes. Why is that important? When you crush epithelial cells, pro-inflammatory cytokines drip down into the stroma. And that starts all sorts of bad things. It's in motion. You start to get activation of keratocytes as myofibroblasts. That causes the haze and the regression that we all know so well.
So here is the mini PRK technique. I'm using the ORCA EBK device to manually remove only as much as epithelium needed to fit the ablation and the transition zone. We've, of course, studied this on the X500 excimer laser in order to achieve the exact diameter, and it does take some practice. You can see how I'm orienting my EBK device in all different directions to remove only as much as possible. Very interesting technique, and it'll heal in 3 days.
Okay, so the first long-term clinical report of this procedure for surface ablation was performed by Dr. Matzliah Tayyib of Israel, and he did a prospective study, randomized, comparing EBK to classic laser scrape on 100 eyes with 6 months of follow-up. So group A was the EBK group, 50 eyes from 25 myopic patients, ranging up to -8.25 diopters of myopia at mean age 25. Group B, the PRK group, PTK, 35 microns, and then the hockey knife, so the classic laser scrape, 50 eyes, once again, ranging in age from -1 to -850, mean age 25.3 years. Here you see the maximum pain at daily intervals, a huge difference over the first 5 days between the EBK group in gray and the control group that had the hockey and the knife in brown. Huge difference. They began to approximate each other by day 5, but there was still separation. If you look at the graph on the right, the percentage of patients reporting any kind of pain or discomfort, huge difference in favor of EBK, the lower gray columns. And if you look at epithelial healing time, the mean percent of epithelial recovery, you can see it was much faster with EBK. Now, this is interesting. It impacted long-term results. The percentage of patients within a half diopter of desired outcome at 6 months within a half diopter of plano, 98% with EBK versus 70% with classic PRK, and 5% of the patients had grade 2 haze, but that was in the PRK group only. There were 4 enhancements needed in the PRK group only. 2 for eyes that were -75, 2 eyes were -1. So it even impacts long-term results. Now, Dr. Kanellopoulos is one of the top surgeons in all of Greece, all of Europe, actually. And he published in Cornea, Bowman blunt keratectomy versus dilute alcohol epithelial removal in myopic PRK, a prospective contralateral eye study with excellent results. He also did a pilot study using EBK for epithelial removal in the surface ablation combined with cross-linking, known as the Athens protocol in keratoconus patients. It was a small pilot study, only 5 patients, and they were treated contralaterally, comparing clinical outcomes of the Epi-Clear device with mechanical scrape alcohol assisted. And the Epi-Clear performed superiorly to the standard technique of alcohol-assisted epi removal. All the patients reported less discomfort, no pain in the Epi-Clear eye. There was 1 to 2 days faster reepithelialization, and below you see 3 of the 5 cases. Case 1, you see the EBK, the first column, if you will, is EBK 3 days post-op, completely healed, whereas the contralateral eye still has a significant epithelial defect in the left eye. Case 2 in the middle, the PTK eye is the right eye, and you can see it still has a sizable epi defect at 3 days post-op, whereas the EBK defect is very small, almost gone. And case 3, a 38-year-old, the oldest of the 3, the PTK on the left, still a sizable defect, no defect at all on the right in the EBK eye. So he felt these early data were compelling for the potential advantage this new technique had for faster, safer reepithelialization, less discomfort, erythema, and light sensitivity. This is a typical one-day post-op of mine, but using EBK technique. 20 over 25 plus uncorrected, 3 days post-op, 100% reepithelialized EBK technique. So it's also quite popular to use EBK in Europe. Professor Marguerite McDonald of Poland presented at the ESCRS winter meeting. EBK refractive procedure in 120 patients with myopia and myopic astigmatism, 2 years follow-up, characterized by very high safety, efficiency, and stability with very high quality of vision. And it was not a randomized study. All the patients received EBK, but she was extremely impressed with 2 years of follow-up by the safety, efficacy, stability, the refractive outcomes, and the quality of vision. Now, Dr. Rohit Shetty is one of the most famous surgeons in all of India. He has a huge practice, and he also publishes a great deal. He published in Current Eye Research Safety and Efficacy of Epi-Bowman's Keratectomy and PRK and Corneal Collagen Cross-Linking, a pilot study. He works out of Bangalore, India, and he compared EBK versus mechanical scraping. He had two groups, the PRK group and the cross-linking group. In the PRK group, he stuck with low myopia, spherical equivalent 4 diopters or less. He had 60 eyes of 30 patients, EBK with Epi-Clear in one eye, mechanical scraping in the other eye. Group 2 was progressive keratoconus. They were getting cross-linking, 44 eyes of 44 patients, 22 eyes had EBK, 22 had classic mechanical epithelial removal, and cross-linking was performed on them all with the epi-off technique. So he did a lot of intraoperative and post-op measurements, speed of epithelial removal, how fast it took him to do the case, debris and epithelial cells remaining, integrity of Bowman's layer. He looked at pain, the duration and the pattern of reepithelialization, and the amount of subepithelial haze. So here you see the pain score. The patients were given these simple diagrams, and they just checked off which one matched best how they felt. So if you look to the left, PRK, immediately post-op, immediate. There is a difference in pain in favor of less pain with EBK. You see the p-value 0.009, very statistically significant in favor of EBK. And even at 3 days out, there's a difference in the pain score in favor of EBK. And if you look for cross-linking, you see exactly the same pattern. You see a huge difference in pain immediately post-op in favor of EBK. And 3 days post-op, the difference is still very statistically significantly in favor of EBK. Now, Dr. Shetty is a very fine surgeon. He was shocked when he did spectral domain OCT of his classic standard epithelial removal technique cases to see that he had left clumps of epithelium and that there were nicks in Bowman's layer. And you see the clinical image above to the right. So he was impressed with his intraoperative spectral domain OCT images. You see a typical one on the top, Epi-Clear, intact and smooth Bowman's membrane. Down below to the right, mechanical scraping with damage and nicks to Bowman's membrane. And he looked at the epithelial profile with OptiView. So a week out, you see pre-op on the left. These patients obviously had some astigmatism. The Epi-Clear blade, regular, smooth corneal epithelial healing on the top right. On the bottom right, with mechanical scraping, there's irregular healing of the epithelium and epithelial thinning in the temporal quadrant. So a much different recovery. He also looked at corneal haze with the Scheimpflug imaging. The Epi-Clear blade up top and the mechanical scraper down below. So the device can detect haze very accurately. 20.4 units for mechanical scraping, 17.1 for Epi-Clear blade. So at 1 week, there was a significant difference in corneal haze. And this just is a picture of what happens over time with EBK on the top versus PRK. And you see stage 1, stage 2, stage 3 healing. And as you'll see, if you look at the PRK images, the last image bottom right, there is a very pronounced, almost like a Mercedes-Benz sort of trifold closing of the epithelium, which is disturbing to vision, as you will see. So here is surface ablation with Epi-Clear, day 1, top left, day 2, top right. But by day 3, which are the bottom 2 images, the epithelium looks really good. And that faint Mercedes-Benz sign is long gone. If you look at mechanical scraping, top left, day 1, day 2 on top right, with a very, very marked epithelial healing suture line smack over the middle of the pupil. Bottom left, you still see the epithelial suture line on day 3, and then bottom right is another image from day 3. So just to sort of show them side by side, the difference on days 1, the top 2 images, and days 3 are remarkably in favor of the healing pattern that you see with Epi-Clear. Shetty also used the OCAS HD analyzer by Visiometrics, the OCAS optical quality assessment system, to look at image quality. PRK with EBK is on the left, mechanical scraping on the right. So in this system, predicted vision 100% 0.9 is 2022 and 0.6 is 2033. So at 1 week, you see that if the rest of the eye is healthy, there's a normal retina and there's no cataract, the difference in the optical quality between the two is very dramatic, and that is reflected in the difference in visual acuities. By the way, the modulation transfer function, the higher the number, the better. So much higher for EBK at 26.4 versus 17.6 for mechanical scraping. He also looked at the objective scatter index. So this is the scatter index convolved with an image of an infant. And what a difference. So at 1 week, you see the ocular scatter index down. If you look at the color bar down left, it's in the green, it's in the normal range. Whereas if you look, that's Epi-Clear on the left. You look at mechanical scraping on the right, you see the arrow is just at the edge in the yellow zone. And it predicts OSI 1, basically a virtually perfect score for Epi-Clear, and 1.9. So the optical quality is twice as good at 1 week if you've had Epi-Clear. Now, this is Albin and Groden, 2 very fine surgeons, high volume surgeons. And you see a few of their patients. The first on the left, a 45-year-old male. He had EBK in his right eye, LASIK in his left eye. And both eyes were doing well. EBK was 20/25 uncorrected, 1 day out. LASIK was 20/30. In the middle is a 50-year-old female, EBK in both eyes, 20/15 in the right eye, 20/20 in the left eye, combined vision, both eyes, 20/15. And to the far right, a 30-year-old female, 1 day out, EBK OU. So 2015 OD, 2020 OS, both 2020. Oh, look at the photographs. No red eyes, very comfortable. You would never know they'd had surface ablation the day before. And here are more 1-day post-op photographs from Groden. So you can see, very, very impressive. Now, Johnny Gayton is also a high volume surgeon. He did some EBK patients and they are quite good. 1 day post-op with EBK in the right eye in this first patient, 20/40, no pain, comfortable, 50-year-old female in the middle. By the way, that was a 71-year-old male. A 50-year-old female in the middle, 20/40, her right eye had EBK. You can see that the operated and unoperated eyes look the same. They're comfortable, they're open, they're white. And on the far right is an 18-year-old female who also was 20/40 and comfortable the very first day. So in conclusion, surface ablation and epi-off cross-linking usually cause clinically and statistically significant post-op pain. EBK provides better clinical outcomes in every way you can measure. It prevents and decreases post-op pain, and it provides faster epithelial healing, more rapid return of vision, and better long-term outcomes. So thank you very much. I will turn it back to Bill.
Marguerite, thank you so much. That was just a great overview of EBK technology. I've heard some of your talk in the past. Obviously, you and I have been doing this for a while, but you've brought so many great clinical pearls, and all the results are just a game changer. I mean, it's why I feel so lucky I've been using this technology. And I look back, it's been since 2016. Marguerite, a couple of things. When you have patients that come to you that are thinking about refractive surgery, what do you tell them if they're trying to decide between LASIK and PRK with EBK technology? How do you just explain why you're a big believer in PRK with EBK for patients that, that are good candidates for PRK?
I never dump on LASIK. LASIK is a fine procedure with good outcomes, but I just say, do you know we can give you excellent outcome, a comfortable procedure, and speedy return of vision without cutting into your eye? And they say, really? And then I describe EBK. And patients love it. With LASIK, there are various ways to present it, but you have to tell the patient that they're going to have an incision. And, the glorious thing about EBK is that you get the same excellent results, you get the same comfort, and you don't have to worry about a flap. You can't have a flap complication if you don't have a flap.
Yes, those are great points. And we're lucky. I mean, now that we have, LASIK is a wonderful technology. PRK is wonderful. We have SMILE, of course. But it's really nice that we can offer PRK, but also with this technology, patients have such a smooth experience. Max, do you want to share your experience with? I know you're going to give us a presentation in just a minute, but just any thoughts on just Marguerite's talk, and what was impactful from her talk, or anything, any thoughts on the EBK technology?
Yeah, when I first started using it, also like you in 2016, 2017, I was a little reluctant, taking something off the cornea versus putting an alcohol well and just letting it soak. But it's remarkably safe. I just think it's incredibly safe. I think once you start using it a few times and you get comfortable with the device, you'll realize that you can really do no harm. And that's beautiful. You can control the size of your ablation zone, how large you make the epi defect. And as Dr. McDonald pointed out so well, like it heals fast.
Yeah. Yes, I will share that I came from alcohol too. I was using alcohol-assisted PRK for years, and I was really happy with the technology. I thought, this is great. They were uncomfortable, and we're getting through that. And then when I switched to the EBK technology and stopped using alcohol, all of a sudden the patients were healing faster, much less uncomfortable. I mean, the speed of healing just made a big difference between alcohol and using the EBK technology. So the speed of healing, and then also comfort, just night and day. So it's been a really positive change for me in my practice since I switched over. Let me ask. Go next question back to Marguerite. Marguerite, is there any limits for how high of myopia? I guess obviously not to huge levels, but are there any limits for when you offer EBK, or can EBK be used for all types of PRK procedures?
I use it for all types. There is no limit. If you would do PRK on a patient, you do EBK. There is no limit.
Yeah, I found the same thing. And Max, So I agree with you, Marguerite. Max, just share also, you were mentioning how you've been doing it for quite a while. Is there a learning curve, and do you want to just describe that? I know it's been a long time since you started
Yeah.
with this.
Yeah, I think the learning curve, the main learning curve is just, because we're so used to not breaking Bowman's membrane, we're so careful if you ever have a blade or a scalpel that you just don't want to nick Bowman's membrane because it could create a scar. I think that's what everyone's concern is overall. And you can't, that was the part that I kept asking over and over again before I ever used it on the eye. And then when I finally started doing it, you won't nick it. And I was always a little concerned maybe the plastic on it would somehow be, maybe there's something wrong with, there might be a barb on it or something. But you know what? Doing a lot of cases overall, I'm sure just like you guys have, doing a lot of cases over all these years, it is excellent. It's just beautiful. You just have to trust it. It'll come right off. The epithelium comes right off. It scoops off, and it has a nice blend in the periphery, as the picture showed. And one other thing I would say, going back to the alcohol, is that sometimes when you put alcohol well on a patient's eye, they feel that low pH, and they bell up, and you don't have to worry about that here because there's no pain or discomfort even as they're taking it off. So you don't have to worry about the alcohol splashing all over the cornea, damaging the stem cell or the limbal cells. And it's just such a nice, clean procedure that very elegant, easy to watch and easy to do.
Oh, thank you so much, Max. Marguerite, do you want to share your thoughts on the learning curve and what you tell surgeons that are new to EBK and how to get involved, I guess, how to get experience with it?
I think there's virtually no learning curve. I mean, as you just heard from Max, it's virtually impossible. I mean, you cannot damage the cornea with it. It's designed perfectly. So, you watched the little tape I showed for about 20 seconds. I'm sure you will also see some footage from Max, but you watch a case or two and you go do it. I mean, it's just really impossible to harm a patient with the EBK device.
That's yeah, I feel the same way. Thank you so much for sharing that. Marguerite, Dr. Whitley had a question, which is basically, since you started using the Epi-Clear device, it has allowed you to do PRK for higher levels of myopia than you did when you were using alcohol. Has that changed your thought process, or is it still, yeah?
No, I have the same limits that I had before. Better outcomes, but I haven't reached up higher into the range of myopia. No.
Right. I would agree. I mean, I think you can go, I mean, whatever your range is, I think you can do any range. I've definitely dropped my range with the ICL, Evo ICL being available for those high levels of patients with high levels of myopia. So, but it's a great question. Thank you, Dr. Whitley, for sharing that question. Well, why don't we go, Max? Why don't you jump into your presentation? I'm excited to learn from you and to hear your thoughts.
Yeah, sure. Let's see if I can make this thing work. I know it's tricky. Everyone see that okay?
Yes.
All right, welcome everyone. Thank you for spending your night with us. And it is the end of the day, at least here in San Diego. So thanks again for being with us. Hopefully we can show you a few things. My talk is a little bit on the other clinical uses of Epi-Clear besides refractive surgery and PRK. Just like Bill and Marguerite, I do all refractive surgeries. So anything that we can do to get rid of their glass and contacts, I'm in, and we do all kinds of procedures just like everyone else. And every once in a while you'll get like that tiger in the room, like you think you got it all set up, and then they come in with all kinds of pathology on their exam, and now you're trying to figure out like why you can't put in a multifocal lens or do a perfect LASIK and get 20/20, and just because they have all these different problems with their cornea that just either they never knew about or no one told them, and so we get tasked with trying to see if we can fix some of these up and then still somehow salvage their eyes so they can get good vision without glasses and contacts as much as possible. So it works really well. Like for anterior corneal pathology, it works really well for epithelial basement membrane dystrophy. You see this quite a bit, especially I feel like in the older patients because they're coming in now for cataract consults or evaluations, and they have that kind of subtle epithelium that's just not right, and it's affecting their topography maybe, or they might have symptoms. Recurrent corneal erosions, which one thing I wanted to talk about, that obviously is affiliated with the EBMD, but also sometimes if they've had PRK in the past, they end up with alcohol. That is, they sometimes get recurrent corneal erosions, but that epithelium never really sticks down as well. And so they sometimes get RCE for that. And then, of course, you get Salzmann's nodular degeneration from chronic, let's say, contact lens use or dry eyes or whatever. Normally, we just watch these things, but sometimes if it's affecting the cornea and it's affecting your readings and your measurements or it's causing symptoms, we need to treat it. And I use the EBK. So the thing is, I love this device because you can actually, as I was saying earlier, you can actually be pretty aggressive on the cornea, and you're not going to break Bowman's membrane. So you can just push once you feel comfortable with doing this. You just push down, and it'll just come right off. And this is actually Dr. Trattler's video. Thanks, Bill, for letting me use it. But it's the same concepts we all do. You just have a nice, slow, methodical movement of taking that epithelium right off the cornea. You can make it any size you want. So you don't have to go from limbus to limbus. If you're doing a cross-linking case, for example, and you want to concentrate the riboflavin in the lower part of the cornea over the cone, you can actually have most of the debridement on the cone area. Or if you're doing a Salzmann's nodule and you're just taking off the nodule, you don't have to spread alcohol over the entire eye. Two things on this video, I would just show it one more time, that I sometimes do a little bit differently. I do this exact technique in terms of learning curve. If the patient does have a little bit of movement, you can take 0.12 forceps with your other hand and just hold the eye for stability. Rarely do that, but you can. And sometimes the eyes do tear a lot. And I would say one learning curve or one pearl I would recommend is trying to keep the cornea dry while you're doing the procedure. It's much easier to see the epithelium come off versus if you're looking through a lake. So if you do notice tears, the eye welling up or something like that, I would just take a Wexel and dry it. But that's probably my only two pearls. Hold the eye if you need to for stability and keep it dry. And it takes literally 15, 20 seconds max to take off the surface.
Right. Do you want to comment? Is it unidirectional or bidirectional?
Yeah, you want to go. You want to go. That's a good question. You want to kind of go from if the orientation of the device is in this manner, you want to go from left to right. It works the best because that's where you're scooping from, and
Yes.
and you'll see that's exactly what's kind of going on here. If you decide you want to go toward the inferior part of the cornea, you would just take your hand and orient it so that it actually continues to go from that left to right. If you go the other direction, you're not going to get the scooping mechanism of the instrument. It's you're kind of working against it. So you want to work left to right. Or I should say, sorry, right to left. Just the way this was going.
Yes.
Right to left.
Yes.
Sorry, right to left. And that's what you'll see. And when you see the device under the microscope, you'll see the two. As I think Marguerite showed in her slides, you'll see exactly what it looks like, so you can understand why it works that way. Yeah, it's a great question, actually. One other thing is, and then, once you take off the pathology, whatever it might be, you obviously don't want to return. So this is where, I don't know what everyone else's position is, but oftentimes nowadays we're using amniotic membrane. I'm really agnostic to what, that's a whole different discussion, but I'm really kind of agnostic to which membrane we use. So I have actually all the different membranes in my office. And it's kind of, we'll just use whatever. But I think the key is to sometimes put an amniotic membrane on the cornea just to promote faster healing. And then we use a contact lens. I usually like using the actually the Air Optics Night and Day is the one that is our go-to, or the Oasis. But we will put the contact lens on, and so you can go straight to the bandage contact lens without the amniotic membrane, or you can put an amniotic membrane on as well. And sometimes that'll help promote the healing. And avoid recurrence of the same pathology you just got rid of. And one other thing, I'm not a biller. I'm not a biller coder of any sort, so I'm probably the worst guy in the office for this. But in terms of concepts, if you're going to go down the medical path of doing this, then you want to do it like if you build superficial keratectomy, that's a 65435 code, and I frankly do it the most conservative way possible. I just do the superficial keratectomy and I put the amniotic membrane on right there on the spot and put the bandage contact lens. And I know So I just put both codes on. I know I take a little bit of a hit, but that's how I do it because I just want the patient to get better as fast as possible. That's just how I do it. But if you want to like optimize billing, and that's kind of what you're trying to do, then I think there's other ways to do it. For example, you can do the SK one day and bring them back the next day and put the amniotic membrane on as a second procedure for a persistent epithelial defect. I don't do all that, but I'm just saying I know some people can or do. And so there are ways to probably optimize your reimbursement, but I'm about just getting the patient better as fast as possible and basically out of my office. So that's kind of that's been my technique. That's all my slides, Bill.
I love it. That's perfect. Thank you so much. That was a great overview and just talking about the different, I guess, pathologies that you can use this technology with. Great talk. I'm going to turn this next question. We have another question from Dr. Haft, or first question from him, but another question that was asked. I guess, Max, I'll ask you first since your picture's right here. Can you use the EBK device with a patient in the slit lamp? Have you ever done that before?
I have. It works and it can be done. It takes a little, I would first recommend doing it under the microscope or with them laying down because you just have a little bit more control, at least until you feel comfortable using the device. And then once you're pretty good at using the device, then I think you can do it in the sun lamp. Frankly, I like doing it under we have the laser in our office, so we have the micro, everything there, so I can cover the lashes. I feel like I just get a cleaner field to work in, and I like that better. Yeah, it's just more surgical, but you could definitely do it in the sun lamp. I'm curious, actually,
Marguerite.
Bill and Marguerite, do you guys do the sun lamp, or it's a good question too.
Yeah, Marguerite, you're muted. Marguerite, you're muted.
I don't know why it keeps muting me. So I agree with Max 100%. I've never done it at the slit lamp just because I want the cleaner environment. I want to drape those lashes out of the way while I do this. Yeah.
Yeah, I would say the same way because it's just easier to do. I guess in our office, since we have an area, we have our laser in our office, so it's easy to have the patient lie flat and use that microscope. So I'm the same. So okay, thanks everyone. These are great that's a great question, great comments. I know I had another question. Marguerite, when you have a patient with a previous LASIK flap and you're going to do PRK over LASIK, can you just describe how you use the EBK device and how you avoid like not injuring the LASIK flap? I don't know if you've had that type of case before. Or...
Sure, I have. So just be very careful to stroke from the center out. If you stroke from the periphery in, you have a great chance of being able to lift up that flap. So stroke from the center out and you will stay out of trouble.
Perfect. Max, any other thoughts on that? Marguerite, you got a great pro. Max, have you had the same scenario?
Yeah, totally. Yeah, totally. Yeah, same thing. And if you know where the hinge of the flap is, you can also go a little bit from the hinge away. But I would stay with the center because you know that's going to be good. I've also done it with RK patients, and then so with RK patients, if you're doing a PRK over the top for some reason, then or you're taking off some kind of pathology there, I would just be a little careful, as you know, when you get to the incisions. But you can actually it comes right off. It comes. You just have to be a little aggressive. Once again, just be comfortable pushing down a little bit on the eye, and you're not going to harm anything as long as you don't push on the RK incision itself. You'll be safe.
And also staying with the RK incisions, staying with the blade perpendicular to the incision.
Yes. Yep.
If you start swatting at it along its axis, you could, even after 40 years, crack it open.
Correct.
Oh, that's another great pro. Max, is there an optimal angle to hold the Epi-Clear device when you're using it? Like, how are you like orienting it?
Yeah, I usually I guess I never thought about it. I think whatever it takes to get the epithelium off. But I think I go probably 90 degrees. I'm just thinking about it. I think I go 90 degrees and maybe a slightly to the left, and just to kind of get the mechanism to engage. Once you get a plane, then you can just start kind of peeling it all off. And so I sometimes maybe go slightly, bend it a little bit to the left. You remember, you're going from right to left. And so as you're going right to left, I might bend it a little toward the left to make it slightly less than 90, just to get the edge of the epithelium started. And then it'll scroll right off.
Beautiful. That's a great way of describing it. I think as you're kind of using this technology, what you see is, as you said, if you get an edge, it makes it so much easier once you get started, and this kind of really comes along very nicely. And as kind of Max showed in the video and elsewhere, sometimes you do have to kind of move your hand around in different angles to really be able to really engage that the two heads of it so that it really easily slides off the epithelium. Do you guys want to talk about briefly your post-op regimen for drops? I don't know. Again, Max, I guess you're up. You have your photo here. So do you want to share what you're doing post-op with, let's say, PRK? What are you typically using drop-wise for your patients?
Yeah, I use the usual stuff. I use antibiotic and steroids, and then an NSAID if it's not too expensive for the patient. The topical NSAID I use once a day for 3 days, and then the antibiotic steroid under with the contact lens. What's amazing, actually, it's a standard PRK protocol. But what's amazing is really no pain medication. I mean, I think that's the most. I mean, maybe they'll have some Advil and maybe some Tylenol, something like that. But I think those patients will take Tylenol, Advil for everything. So that was gonna, that's just the personality of the patient. But they're not taking anything excessive. Almost never do I have to call in anything stronger than that. And whereas I think when we're doing PRK with either Diamond Burr or ETOH, you're routinely getting calls about extreme pain, and I don't know. I never get that call.
Yes, I agree. Marguerite, what about your post-op regimen?
Well, my post-op regimen is similar to Max's with one exception. I learned that if you give oral steroids, I know that sounds nuts, but if you give oral steroids, a giant dose, like 80 milligrams by mouth, 20 minutes before you fire the laser, they walk in the next day like nothing happened. Now, I will say I developed, and then 80, 80, 40, 20, 10, 5 off. So they're off in 6 days. I will say I developed that long before I started doing EBK. And I'm almost afraid to see what happens if I don't use it. But EBK is so effective at pain control by itself. I should really give it up. Of course, I do it only to healthy people who aren't diabetic. I mean, I'm very careful. But I think, and I also used to give them 0.1% tetracaine, preservative-free, that they could use up to every hour while awake for the first 3 days. I have it made up by a compounding pharmacist. And that was shown in a very careful study out of St. Thomas in London to be effective, and it doesn't slow reepithelialization. But once again, I think, I'm just getting up the courage, since I've done it for so many years, to stop the oral steroids and stop the dilute tetracaine. I just don't want anybody coming in anymore, in a bathrobe with a garbage can, like they used to in the old days.
I know. It's really funny. I think back, my favorite talk I gave so often, because I was a big fan of PRK early on in 2002, 2003, was my talk title was Pain Control with PRK. And we used to use a popsicle, the ice popsicle, everything you could imagine to try to make patients feel better. And this has really changed the game. Patients are so much more comfortable. Margaret, I'm sure if you stop the prednisone, I think it was definitely with the old technique, it is helpful. I bet your patients do just as well. My technique is similar to both of yours as well, though. So I use a Bromphanac once a day. I'm using a steroid drop, and then I do use 2 antibiotics just because I always worry about some type of resistance. So I use 2 antibiotics, and then day 3. So we do the procedure on Tuesday. On Friday they come back. We take off the contact lens, and that's when I stop the antibiotic drops at the visit.
Which 2 antibiotics do you use, Bill?
So I'm usually using Polytrim and Moxifloxacin. Again, just trying to get broad coverage. I did get burned with an infection a number of years ago. It's funny how one single case changes how you treat patients. I just thought that maybe that would be helpful. Again, I don't have any studies to say it makes that much of a difference, but I'm just doing it probably for me more than just to be as safe as possible.
The case that you had, what did the culture grow?
It's been a little while. I don't recall exactly. He didn't tell me, though. He was also immunosuppressed. And so I found that out afterwards. And I'm not sure how compliant he was with the drops anyway. So it was a tough case. The patient did do okay long run, but it was just very stressful because obviously these patients, we just want to have the best outcomes for all of them. So, we care about each of them. And so you always try to make little, tinker your regimen just to figure out how you can avoid those type of things in the future.
Oh, one little pearl. There are very few smokers left, thank God. But if I determine that someone is a smoker before I do surgery, I won't do them. I won't do them. The toxic fumes directly, plus the metabolism of a smoker, they re-epithelialize so poorly. But there aren't too many left, thank goodness. They've all
Right.
given it up.
That's a great pearl. The next question came out is from Dr. Hubex. And Dr. Hubex asked, how many cases would you suggest for a surgeon to get comfortable with the EBK device? I know, Max, you already said not many. Marguerite, how many would you recommend?
2 or 3, max.
I agree. I think it's pretty fast. I think there's a little technique. You got to get just used to like moving your arm around to make sure you're always moving in the same direction, because it just makes it that much easier. And you start to see that are some variabilities in how sticky someone's epithelium is. But at the end of the day, these cases all go really smoothly. And it's pretty amazing how well the patients do postoperatively. That was a great question. Beautiful. Well, I know we're already at 8:51. I'm not sure. Marguerite, do you have any last comments or last thoughts you want to share with the audience?
I really think that there is a chance for EBK, an excellent chance, to revitalize laser vision correction. We know there's a dip in volume of LASIK in particular. It's not entirely due to the introduction of the EVO ICL. And I think there's a chance to present this to our patients in a very different way, so that the market is revitalized. Also, I think we can teach cataract surgeons who never do laser vision correction how to do an EBK procedure to tune up their patients where you haven't nailed your refractive outcome. I mean, there would be more and more and more premium IOLs implanted if doctors knew how to deal with a refractive miss. And the ablations are so tiny. They're usually less than a diopter. It's so easy to teach a cataract surgeon how to do EBK. So as Yogi Berra said, the future lies ahead.
Oh yeah, I love it. Those are great. Thank you so much. And Max, how about any of your thoughts that you'd like to share?
Yeah, I guess I would say, like, it's a nice technique to clean up the cornea a little bit if someone has EBMD or scars in their cornea and you're trying to get their cornea a little bit more pristine, at least the tomography better, so you can put in the right lens. And normally when a patient comes in with 65, 70, 80, there's so many octogenarians now, we're reluctant to take off their epithelium because we know it's going to take forever to heal. And now at least we know that we have a fast healing, almost pain-free, a very low pain type of technique that we can feel safe on. And so I think it does help with cataract surgery and just optimizing the cornea prior to surgery on some patients. And then on the refractive side, just what Marguerite said, yeah, I mean, patients are fearful. I don't know why, but they're very fearful that LASIK flap's going to move. And I think they're overly fearful. But on the other hand, but now we can at least tell them, look, we can do EBK and we can get you better pretty fast. We're only going to be out of commission for 3 to 4 days as opposed to 7 to 10. And I think that makes them feel a little bit better, increases the pool of patients who might want to do refractive surgery.
Oh, thank you so much. Those are great comments as well. And I'll just add on to these great comments that one thing I've learned, especially recently, is with ChatGPT, is that when you tell a patient about PRK, even though I say the word EBK, when they go to ChatGPT, it says it's a 5 to 7 day recovery period, couple months for the vision to really recover. It's very painful. And so ChatGPT is not really positive towards PRK. So I have to, when they talk to me about that, and they come back for their second visit, part of the procedure, I explained, wait, you asked the wrong question. You have to ask about it with the EBK technology. So I carefully, when I text people like the procedure they're going to have, and I always say PRK with EBK technology, feel free to research that, and you'll see it's a very quick recovery, 3 days, minimal chance of having significant discomfort, and overall the vision recovers very quickly. And then they feel much more comfortable with the procedure. So just be aware when you're talking about PRK to always include the EBK technology, because that does come out better on ChatGPT than PRK alone. So beautiful. Well, thanks you guys.
Good night.